all this stuff on. This thing on? Yeah, it's on. Alrighty. So, so we're gonna get started on a bit of back, thorax, and cardiac anatomy. So just first off the bat, if you guys watched Nasangi's lecture, that was a good decision because, yeah, this one could be a bit grim. But if at any point throughout the lecture, any of you guys have any questions, and I'm not like looking up or I don't see you stick your hand up, just like shout out. I don't want this to turn into a zoo, but if it happens, it happens. The other thing is, all jokes aside, if you are watching it later, if you're watching it from the live stream and you're like, that's wrong, what's he talking about? Send me a message. That's my Facebook profile. Bit of false advertising, but who isn't, right? And, oh yeah, the last thing is, Nasangi, if you watched hers, had 122 slides and got through them in about 45 minutes, and I have 60. So it's going to be a bit of a change of pace. We're going to take it nice and slowly, a bit chill. Hopefully no one falls asleep, but again, if it happens, it happens. So, all right. These are just like some basic tips. You guys all know how to sit an exam at this point, but I really have to fill the time somehow. So the first one is like, just chill out, right? You guys are all smart enough to pass this exam. You're all going to be fine. The hardest part of med is getting into it. So just like from pre-clinic out, you'll be fine. Use some previous exams to revise. Those will teach you what the high yield content is, and then you can just study that. If you really want to get that 100%, gonna have to put a little more effort in than that. But if you are sort of just going for the pass like I did, then this is the way to do it. Do the Moodle quizzes. Oh, what's going on there? This technology. Oh, all right, we'll put it up here. Yeah, do the quizzes on Moodle, because more often than not, med faculty will just take questions straight out of the quizzes and put them in your exam. So if you do them, then there's a good chance you'll just find some free marks there. And have a look over the pathologies and stuff you guys have done in ICL. ICL is like examinable. It doesn't seem like it, but yeah, I know, a bit grim, isn't it, Cry? But it is examinable, so have a look at that stuff. Now, in terms of studying anatomy more specifically, if you're gonna rote learn, don't go to like a textbook and just learn every single artery and every single like tiny little anastomosis of, you know, something, because you just like, it won't come up. It's not an efficient way to study, and focus on like the high yield content basically. Don't study HEP is my advice. We all love Craig, but realistically, the stuff he puts in his lectures, or the stuff he'll put in his exam questions, will fall into one of two categories, where it'll be common sense or it will be something you will never be able to get, and you'll just have to guess it. So don't bother studying it. You'll either be able to work it out from the question, or no one will get it right. And then the last thing is like sleep the night before you have to do the exam. So yeah, probably not the best role model for that one, but there you go. All right, so we're gonna start off with the back. This is sort of the level of humor it's going to be at for pretty much the entire. So strap yourselves in. All right, so we've all heard this one. This one, I don't think that one fit into her slides so well, and it's also a little bit clunky. So, whoa, something's happening here. But yeah, it's it's pretty much true. Like embryology, if you want to learn it, come learn it. Some of it can be interesting. But realistically, they're just going to throw you a question like, which week does this, like, you know, nerve appear? And no one will know. The other thing though, and in fact, this was on my other slides that I should have mentioned back then. In Langman's embryology, which you guys should, because you all got it legitimately. In Langman's embryology, they've got these little blue boxes, and it's the same in Morandale. They've got these big blue boxes at the end of every chapter. And in the anatomy department's sort of desperate quest for relevance, they take those blue boxes which say clinical correlates or like clinical box, and they just put it straight into your exam because they're like, yeah, that's what the kids want. That's what, you know, a bit of clinical relevance, bit of something that'll help them later on. How are we going for time? Yeah, good. So if you guys want to find some easy high yield content, it's usually in those little clinical bits. And the same thing, just like in your books, they've got bits that are clinical. So have a look at those. That's what I base my slides off. I haven't got through all of like the blue bits in the textbooks, but if you wanna get some free marks, they're there as well. So we'll start off with a bit of embryology, even though it doesn't really matter. Realistically, this is more than you need to know. The ectoderm, and you know, so the spinal cord itself and your central nervous system and all your nerves come from your ectoderm. The ectoderm forms the neural plate in the trilaminar disc, and then some stuff gets released from the notochord, and it makes like a neural tube. If you don't have enough folate, then that doesn't happen properly, and you get spina bifida or another neural tube defect. So exencephaly and anencephaly are second year content. You don't need to know them. They're irrelevant for you now. But spina bifida, I believe you guys had an ICL on, because we did last year and they don't change them. But that happens when the caudal or posterior neuropore, so like the back end, the bottom end of the neural tube doesn't close. And that happens in about week 4. Our ICL tutor told us it happened in about day 6. So if you had 2, it's not correct. Believe it or not, one of the most complex structures in the body doesn't finish forming by day 6 of gestation. And so we've got a few different kinds. They're here. So like spina bifida occulta, I think about 30% or 10% or something of the population have this, and you just don't know. It's asymptomatic. You might never notice. Meningoceles, like this one here, are when you've got the meninges and a bit of cerebrospinal fluid herniating out through the back. They're not great. They're, you know, surgically you can fix them pretty easily, and long-term, you're unlikely to see much detriment from them. But myelomeningocele, like this one here, are when you get the spinal cord herniating out as well. And these ones are not good prognostically. These are the ones where you start to see your long-term neurological damage. So that's stuff like incontinence and having trouble walking and all of that. And that will happen with these particular kinds. Then the last thing I will mention about the embryology of the spinal cord is that embryologically, the spinal cord extends along the whole back of the embryo. But by the time the fetus is developed and by the time you're born, it's started to move up, and then the vertebrae outgrow it very quickly, which becomes relevant later on. All right, so these are your learning objectives. These are the learning objectives you guys got from, or that I got from your lab book. And those are also the tute questions you did. So we're going to go through the learning objectives and just have a little look at the tute questions. Again, some of these are more relevant than others. So we'll just, you know, we'll go through it as we go through it. So first things first is your spinal curvatures. Now, if you guys have looked at Morandale or looked on the internet, these are described in quite possibly the least helpful way you can imagine. which is they're described as either convex anteriorly or concave anteriorly. And what that means is if you were to stand like with someone anterior to them, then it'll either be convex towards you or concave away from you. And so you want to think about, if you're standing in front of someone, what are the vertebral bodies doing for kyphosis versus lordosis. So for like lordosis, if you're standing in front of someone, the vertebral bodies will be convex to you. And so that's like your lumbar spine. If you stand up really straight, then you can feel that there. And also your cervical spine. Be careful with cervical, particularly next year. It's like cervical or cervical. Don't get that one wrong. Get roasted for that by Peter. It's really sad. And then the other thing is kyphosis, which is your other natural curvature, and that's when it's concave, so curving away from you. And you see that in the thoracic spine there, and you also see it in the sacral spine down there. Now, the kyphotic curves are both embryological, so they're called primary curvatures, and they occur if you just imagine like the fetus is in the fetal position, then it's just curving that way. And then as you start to stand up and start to lift your head up to accommodate for that, so you don't sort of constantly spend your time falling forward, your lordoses develop, and they're both secondary curvatures. Now, pathologically, you can develop pathological curvatures, and that's going to be excessive lordosis and excessive kyphosis. What the difference between like a good amount of kyphosis and a good amount of lordosis is versus a pathological amount, I really have no idea, but I guess it'll either be obvious with the question. So, well, I mean, I do have some idea actually, that's a lie. So like hunchbacks, that's the bad amount of like kyphosis. As lordosis is tricky, sometimes pathological lordoses develop during pregnancy, but they usually go away once the child is born. And then scoliosis is when your spine is bending laterally, which it's obviously not supposed to do. All right. So this is your basic vertebrae. You guys should all be pretty familiar with this. We won't spend long on it. There's sort of like a few bits you need to know to it. There's the vertebral body there. Then you've got your pedicles here. You've got your lamina, which is this bit here, transverse processes and spinous process. If you look at the textbook, it's like, oh, there's 7 processes, but actually 6 of them are paired. So it makes it much easier. So really, if you just think, oh, well, transverse process, superior articular process, there's an inferior one, but we can't see it in this diagram. Those are on both sides. So you don't have as much to learn. All right. So I've got a little bit of activity here. We're going to skip it. It doesn't really matter. So if you want to have a look there, that's basically it. And that was one of your learning objectives. All right. Now, this is actually some interesting stuff. So as you guys might remember from your tutes, in the vertebral canal, this bit here, you've got a plexus of veins. And the interesting thing about these veins is they are actually valveless. Now, what that means is when these veins drain, and it's called Batten's plexus, or Morandale calls it the internal vertebral venous plexus, these veins drain from the perineum, and they also drain from the torso. So the bladder, the prostate, the rectum, and the breasts will all drain into this Batten's plexus. Now, because it's valveless, that allows tumours to just sort of go wild in there. They'll just spread in there, and they can go up and down and do whatever they want. If you have coughing and stuff, it can reflux into like the head, and you can get brain tumours because of this valveless plexus here. So Batten's plexus, or the internal vertebral venous plexus, is usually going to be the one that's responsible for the spread of tumours into your vertebral bodies, just like you can see here. All right, some regional differences between the vertebrae, just to keep in mind. So C1 and C2 are pretty special, so we'll go through them a bit more later. Otherwise, your cervical your cervical vertebrae have bifid spinous processes. So as you can see here, they just have two little spinous processes there. That's all that means. And they also have transverse foramina, which you can't see in here. I mean, you can sort of see the transverse foramina of atlas, but they, oh yeah, you can see them here actually. What goes through there is your your vertebral arteries, which means if those get fractured, then you can have some issues with blood supply to those areas. Then you've got your thoracic vertebrae, which have longer, pointier spinous processes, and they've got articular facets for the ribs as well. Finally, well, not finally, actually, there's two left. But your lumbar spine has like wide, squat vertebral bodies, as you can sort of see here. And that's because they have to bear a lot of weight. The lumbar spine is the major weight-bearing spine. And then the sacrum just doesn't look like any of the vertebrae. So if you can't work out which one the sacrum is, I can't help you. All right, now, C1 and C2, we'll have a little look at. I think I've got them in a slide later. Yeah, sort of. So we'll go back briefly. So C1 is atlas. C1 is called that because much like the figure from Greek mythology who held up the world, atlas here holds up your head. Not quite a task of the same magnitude, but for you med students, it's pretty close. All right. Now, the atlas allows the rotation of your head, so like turning it side to side, and then the dens here is what it rotates around, basically. Dens might also be called the odontoid process of C2 because it looks like a tooth. So if you see this thing here, that's the dens. And these have some relevance that we're going to talk about now. Now, the reason I've included this isn't in your learning objectives, but it just seemed really clinically relevant to me. And last year there was an exam question on it. So we're going to go through it a little bit. So your cervical spine, or your cervical spine, I should say, cervical vertebrae dislocate rather than breaking because they just sort of slide over each other before they'll break. And when they do that, they can basically, it's called facet jumping, but they're interarticular processes, which you can, where's an example? You can sort of see them here, can basically jump over to the next one and lock out. And what that does is it just puts constant pressure on the spinal cord, and that's when you can get some really nasty spinal injuries. If atlas fractures, one of these is an A, I put it in there. So when atlas fractures, you can see that on this form of x-ray, which name eludes me at the moment, but the main thing to look for in an x-ray like this is the gap between your dens, which is this bit here, if you can see that, and the atlas on the other side. So the atlas should be within the sort of margins of C2 there. As you can see, this one's not, it's escaped. And these gaps should be even. They're not because that's a Jefferson or burst fracture. And these will commonly occur basically because someone lands on their head and the sides of the atlas are thicker than the middle, which means it basically gets squashed and cracks open like that. And so when that happens, you get this sort of fracture here. And it's really common, like if you dive off something into shallow water, that's a common way people will get that one, or landing on their heads. Now, axis, on the other hand, hangman's fracture, we had in our exam last year. And what a hangman's fracture is it's the fracture that used to kill people when they hung them. And it's caused by violent extension of the head on the neck. All right, I'm gonna speed up here. And then that one's really bad. That's why they used to use it to hang people. And then fracture of the dens is usually caused by some sort of horizontal force on the head, which just fractures the dens. And you can see that fracture there. It might also fracture like this. All right. Next, so the bony boundaries of the vertebral canal, pretty easy. So you've got your vertebral body on one side and your vertebral arch on the other. The vertebral arch is made up of your pedicles and your lamina there. Oh, that's not it. Fire alarms are going off everywhere today. So spondylolisthesis is caused by spondylolysis actually. Spondylolysis is when your pedicles either fracture or aren't formed and a congenital defect. And basically what happens, if you can see this MRI here, the vertebrae will just slide forward. It commonly happens in L5 and S1, which can be really bad if it happens while you're also trying to have a child, because you just, you've got no space there and just gets in the way. And so that's a pretty common one. We didn't have questions about it. Doubt you'll get asked it. So the vertebral canal contents. Now this one you will get asked about. So we'll go in from outside in. So first off, you've got your bony boundaries here, in the periosteum of the bone, which is just that sort of, I guess, like the skin for the bone. You've got a bit of fat, got the Batten's plexus in there. Then we get to your meninges. Now the meninges are a layer that's over the spinal cord and the brain. It runs over the whole central nervous system. And going from outside in, you have the dura mater, which is a very thick fibrous meninge there. Then you have the subdural space. The subdural space is a potential space. That's why I put it in black. It shouldn't have anything in it, but it sometimes can. And I don't think we'll cover that, but you'll cover that next year. Subarachnoid space. The subarachnoid space is where the cerebrospinal fluid runs. So that one's pretty important because that's where you'll collect cerebrospinal fluid from your lumbar puncture. And then your pia mater is sort of like, if you see it, it just looks kind of like glad wrap over the brain or glad wrap over the spine. It's very thin and it's very clear. So that one just is directly over the structures themselves. All right, so this is what I was going to mention earlier. So when I was talking about embryologically, how the vertebral column and the spinal cord are at different lengths, the spinal cord doesn't grow with the vertebral column. And so your conus medullaris, which is the end of your spinal cord where it becomes the cauda equina, is actually not at the sacrum, like you might expect if they were growing together. It ends up at about L1 or L2, around that level there. And so what that means is your cauda equina is taking up all this space here. And you have what's called the lumbar cistern here, which is just like a little thing to hold CSF. So that's like what a cistern is. And then, yeah, that's pretty much all there is to that. Yeah, so lumbar punctures and epidural anaesthetics. So this was one of your learning objectives, and this one has a lot of clinical relevance because at some point in our careers, we will have to do a lumbar puncture. So lumbar punctures, the point is to either withdraw CSF from the lumbar cistern, or the other option is you might want to put something into the lumbar spine there. So if you are doing a lumbar puncture for a test like for meningitis, so if you're looking for bacteria and you want to take a sample of the CSF, you're going to hear 2 pops. Now, the 2 pops, the first pop is coming through what's called the ligamentum flavum, which is like a ligament that connects all your vertebrae. And so the first pop, you go through that. And then the second pop that you'll feel as you're pushing this needle in is the dura mater. So when you pass through the dura mater, some people will tell you it's the dura mater and the subarachnoid mater, or in the arachnoid mater that you feel is the 2 pops. But the arachnoid mater and the dura mater are basically bound together. So you won't feel that. And then epidurals, you only want to feel 1 pop because you don't usually want to go in past the dura mater, as you can see here. I'm not exactly sure if that's correct actually, but I think you might. But that's for like spinal blocks, in case you want to do a basically a local anesthetic on and knock out someone's legs, or pelvis while you do surgery there. And the one thing about lumbar punctures is they're contraindicated in certain cases of increased intracranial pressure, particularly space occupying lesions. So any masses, any tumors, any cysts, anything like that. If a patient has one of those and you give them a lumbar puncture, you will kill them. Don't do that. It basically sucks the brain down through the spinal cord because the pressure just forces it down. So that's bad. All right. through the foramen magnum, I should say. All right, so the arrangement and pattern of spinal nerve pathways. I'm going to be honest here, I had absolutely no idea what it meant by this in your learning objectives. So I've spoken about two main things. So your numerical designation of your spinal nerves. So the cervical spine is really annoying because it's more like a sandwich of well, it's like a vertebrae sandwich if you name it after the filling. Otherwise, you've got a nerve running over the top of atlas is the main thing. So there's a nerve running over C1, which is your C1 spinal nerve. And then there's still a nerve running under C7, which you'd think would be C7 if you go by how the rest of them are named, but it's actually C8 because you've got that one running over the top of C1. All right, we're going to keep going. And as you get further down, the nerve roots become longer. Now, I don't know if this drawing is correct. I sort of copied it off some ones I had on the internet and used a photo from or used a scan from our lab book last year. I think it's roughly right. So usually you've got your dorsal root here. Your dorsal root, the way I remember it, is like dorsal fins are on the back. And so dorsal, that's all your sensory fibers there. They come in through your posterior ramus and your anterior ramus, and they come in and they don't synapse, but their cell bodies are stored in the dorsal root ganglion there, and then they come in and got the spine and synapse in the dorsal horn up to the brain to become secondary neurons. And then your ventral root, on the other hand, like when you want to vent at someone, you're letting stuff out. So that's your efferent and your somatic efferents there. So usually motor fibers and sympathetic motor fibers, somatic and sympathetic efferents. So I'll upload the slides later, I believe, and I've got some ways to remember some of this stuff that has helped me. Interneurons are just used for reflexes as well. So they carry so if you have a sensory signal that tells you need to activate a reflex, it goes through the interneuron straight back into the motor so that you don't have to spend ages with your hand on the stove while your brain tells you what to do. Disc herniation, so your discs have two parts to them. There's the nucleus pulposus, which is the bit in the middle, as nucleus might suggest for the biology geniuses amongst us. And then the annulus fibrosus, which is like a coating, a fibrous coating on the outside. Now, the main cause of herniation is old age, because as you grow older, your annulus fibrosus becomes thinner and your nucleus pulposus becomes more dehydrated. So that makes everything just much more brittle, and so you're more likely to have a herniation of the disc when there's hyperflexion of the spine. And that might be from fall or from picking something up too fast or anything like that. Now, occur posterolaterally in the lumbar spine. So if you imagine that's usually around this area here or this area here, as you can see, it's rarely in the midline, and that's because it doesn't happen anteriorly, because you've got your anterior longitudinal ligament there, which is really thick and just covers the whole thing there, so it can't break through there. You've got your posterior longitudinal ligament, which is much thinner here, which covers the midline, and so it just sort of herniates around that. And when it does herniate, you're going to affect the spinal root of the vertebrae inferior to the herniation, because the ones superior will actually escape and be spared and go around the herniation, whereas the ones inferior are still making their way down there and they will take the brunt of that herniation. So as you go through your lower limb dermatomes and myotomes, that's going to be more relevant. All right, the muscle groups we're not going to bother doing. There's almost definitely not going to be a question on them. If there is, I sincerely apologize. They're boring, they're useless. I got all the way into about halfway through this semester without realizing that there was more to the muscles of the back than the rectus spinae. So it's like you just don't need them. All right, yeah, there's a nice little. Thank you. Yeah, that was high effort. That one. All right. So, here's your learning objectives again. We're not going to spend long on the thorax. It's mostly done later. So here are your ribs. What what was important from this? Oh yeah, so the true ribs are ribs 1 to 7, and they're called true because they articulate with both the vertebrae and the sternum. The false ribs articulate with just the vertebrae and cartilage, and the floating ribs just articulate with the vertebrae. So here's your floating ribs here, number 11 and 12. As you can see, they don't articulate with anything on the anterior side. Then your false ribs, which is 8, 9, and 10, articulate with the cartilage of the rib superior to it. And then your true ribs 1 through 7 articulate directly with the sternum there. The other way they might be described is as typical or atypical. So ribs 3 to 9 are your typical ribs. They look like ribs. Your atypical ribs are 1, 2, 10, and 12. They are atypical because they don't look like ribs. So number 1's a bit too fat. Number 2's got some stuff, a rough surface on top to have serratus anterior attached. Numbers 10 through 12 are just sort of floating out in space, and so they're a bit odd as well. All right, the ribs articulate with the vertebral, the transverse processes and the articular processes of your vertebrae in a sort of bucket handle movement, and that's so you can breathe. So that one's quite useful. Your sternum is also skeletal, and you've got 3 parts: your manubrium, the body of your sternum, and your xiphoid process. So your joints is the manubrial sternal joint here, also called the angle of Louis. That one's quite important. I believe in the song you had a slide about the angle of Louis and that as a transverse plane on CTs and stuff. So they will quite likely ask you a question about that. I was too tired when I was making these slides last night to put one in, so I haven't. Then there's the xiphoid here, which is pretty much entirely unimportant. So we'll just move on. And the sternum moves in a sort of pump handle way, it's described as, and that's again so you can breathe. Now your intercostal muscles, I'm not allowed to make an anatomy PowerPoint without including some sort of slightly dirty way to remember things, so that's just the way it's got to be. But you've got 3 layers. You've got your innermost ones here. You've got your internals. Now, if you put your hands up to your chin, then your internal muscles run in that direction. So they're sort of running like that. And then for your externals, I will leave you guys to work that one out yourselves. They're accessory muscles of inspiration mostly. There are other thoracic muscles. Upper limb will cover the clinically relevant ones. And if they don't, then that's their fault, not mine. Don't really bother learning them. They're pretty low yield. All right, so the intercostal space and penetrating injuries. This one's also important. They usually ask a question about doing like a thoracocentesis, or a pleural tap, which are exactly the same thing. So in your intercostal space, running from proximal to distal to the bone, you can say van either way. So it's either vein, artery, nerve, going from bottom to top on the bottom side of the intercostal space, or vein, artery, nerve, going from top to bottom in the top side. So as you get further away, the nerve will always be closest to the middle of the intercostal space. Now, your intercostal vein, artery, and nerve are much more important than your collateral vein, artery, and nerve. And so you basically just sacrifice them and aim for the bottom of the intercostal space, superior to a rib if you're ever putting a needle into, I guess it's like in the 5th one, mid-axillary line, I think, to try and, you know, get rid of a pneumothorax or something like that. In terms of what you'll get asked about in your exam, it's just going to be a needle. Maybe a stab wound, but almost definitely a needle if they do ask you about it. All right, arterial supply of the thoracic wall. Kind of clinically relevant, not too clinically relevant. So your descending thoracic aorta has the branches of your posterior intercostal arteries coming off it, and they do the back. I don't have a photo of them here, but they do all your back muscles there. And then the right and left subclavian artery do your internal thoracic arteries which then become your anterior intercostal arteries. So posterior intercostals come from descending, and anterior come from the internal thoracic, which comes from the subclavians. Your internal thoracics then eventually will become they will bifurcate and become your musculophrenic and your superior epigastric arteries. Superior epigastric is second year content. You don't really need to know much about it. Musculophrenic is diaphragm. I don't remember if that's first year content or not. It's all sort of blurred into one. So we'll talk a little bit about the diaphragm and assume it is. Now, and a little interesting tidbit is that the internal thoracic artery can be used in the place of your radial artery if you need to do a bypass graft for some sort of myocardial infarction or occlusion in the heart, because you can pretty much just cut it there, take it off, and stick it to the heart there, and your heart will then get blood supply from the internal thoracics. Now, venous drainage of the thoracic wall, again, not really that important. I only caught onto this stuff this year, and I don't remember if there was a question about it in an exam. I hope not, because I wouldn't have got it right. Right-sided intercostals are all drained by the azygos vein here, and then that will drain into your superior vena cava, and then your left-sided intercostals are either going to be drained by the hemiazygos, which is actually down here, or your accessory hemiazygos, which is up here, depending upon how superior the rib is. I imagine there's a lot of variation there, so probably not worth learning exact stuff. These then drain into the azygos, and then into the SVC, and then into the right atrium, blah, 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 blah. All right. So the diaphragm and the apertures of the diaphragm. So the diaphragm is a muscular sheet that makes you breathe. At this level, that is all you need to know. It has holes in it which let things through. So at T8, the caval opening is at T8. It's the highest one, and it lets through the vena cava and some of your phrenic nerve. At T10, you've got the esophageal hiatus, as the name suggests. It lets through the esophagus, and also some vagal trunks that run with the esophagus. So some of your vagus nerve there. And then the aortic hiatus is at T12, and that has your descending aorta coming through it. There's some other stuff, some lymph and all sorts of, like your thoracic duct, I suppose, is the other important one, maybe for aortic hiatus. Now, the mediastinum is just like a space that we've sort of created. So it's the compartment between your lungs. Description, if you Google it, is between two membranous layers, which I guess is the two pleural layers of the lungs here. You don't need to learn everything in every part of it. Just learn a few of the important ones. So like for this one, superiorly, I've highlighted some of the ones that I think might be important at a first year level. So like the great vessels of the heart, definitely including the arch of the aorta, are in superior, and your vagus nerve in the superior. Anteriorly is literally nothing. And then the middle is the heart. That one's kind of important. And then posteriorly, you've got your descending thoracic aorta and your thoracic duct, which are the main important ones for you guys at this level. Now, the major nervous system structures in the thorax. I've just listed 3 here that I think are good to learn. So the phrenic nerve is the most anterior one. It runs anterior to the hilum of the lung, which is sort of in there. You don't really need to know much about it. A good way that might help is it runs anterior to the pulmonary arteries and pulmonary veins. Then posterior to the pulmonary arteries and pulmonary veins is your vagus nerve that innervates the heart and then continues down to innervate some of the esophagus, sympathetics. The phrenic nerve innervates the diaphragm. If you see phrenic, it means diaphragm. And sympathetic chain ganglion run along the back of the thoracic wall, so the posterior surface of the thorax, and they do your sympathetics for most of the thorax. All right. So, moving on. This one, I sort of was getting a bit tired at this point, so we're not really going to go through into much embryology of the heart here. So, the heart's position with the thorax is here, as you can see. You guys should know that. You should be able to identify the heart by now. So the right atrium makes up the right border on an X-ray, or I guess in terms of the spatial design of the whole cavity. So the right atrium is the right border, the right ventricle is the inferior border, but is also the most anterior part. So I believe we had a question at some point last year, like, what's the most anterior part of the heart? And it's the right ventricle there. The left ventricle is the left border and your apex beat, which is important. And the left atrium is your posterior border, which we can't really see here, and is not so important. So a little bit of embryology. Dextrocardia is a condition. We'll just go through a few embryological conditions as we go through, but basically your heart is the wrong way because your heart is supposed to loop, and if it loops the wrong way, then it ends up facing the wrong way. And this does need to be surgically corrected usually. Sometimes people can be fine if you have situs inversus, everything is swapped and the person's fine. But otherwise, having just the heart the wrong way doesn't really work. So as you can see, this is the right side. The heart is supposed to be facing to the left. Now, your pericardium, Morin Daly says there's 2 layers and then goes on to list 3 layers. So what are you going to do, right? Your fibrous pericardium is really thick. It's really fibrous, as you might guess from the name, and it's not particularly elastic. Then you've got your parietal and your visceral layers of the pericardium, which are just in there. Your visceral layer is pretty much on the outside of the heart, and then your parietal layer is bound to the fibrous pericardium there. In between those two is the pericardial cavity. That is a potential space. It should just have a bit of fluid to help everything move nicely. If it has other fluid, then you get this: pericardial effusion and cardiac tamponade. So a fluid can accumulate in the pericardial cavity, and that's called pericardial effusion. If that happens, then it's not the end of the world. But if it keeps on happening and happens quite quickly, or happens to quite a large degree, like you see here, then you get cardiac tamponade, where basically the fibrous pericardium doesn't expand, everything fills with fluid, your heart can't beat, and your heart also then has its vascular supply cut off, which, as you can imagine, is not ideal. Now, myocardium, you've got 4 chambers of your heart. Again, this is another one of those things where if you don't know it by now, I can't help you. So your right atrium and your right ventricle. Wow. So your right atrium and your right ventricle take deoxygenated blood, send it to the lungs. Your left atrium and your left ventricle take oxygenated blood and send it into the systemic circulation. Now, inside your atria, you've got a few things. You've got these pectinate muscles, not to be confused with the things in the ventricles, which we'll cover in a second, which I don't remember the name of. They are supposed to help with contractile force. We're not really sure what they do. Your auricles are just these little embryological things, and they increase the capacities of the atria, we think. The right atria specifically has the crista terminalis in it, which I believe is this thing here. And that is the border between the smooth bits, which are embryological, and the rough bits, which form earlier. So smooth is newer, rough is earlier, and the crista terminalis is the border between the two. And then you've got the opening of your coronary sinus inside the right atrium, which is the venous return from the cardiac veins. All right, so inside the ventricles, this is the word, trabeculae carnea, or carnae. The purpose of these, unlike the pectinate muscles in the atrium, is to prevent stasis. It's to create turbulence within the ventricle so that the blood doesn't clot. Because if the blood clots in the ventricle, you either get a pulmonary embolism or you have a stroke, neither of which are desired outcomes. Now, your chordae tendineae, I think we've had this drilled into us. I don't know why they've picked the chordae tendineae, but they seem to ask us a question about it every chance they get. The chordae tendineae are just tendinous cords. They're not muscles. They do not pull on they don't actively pull on anything. They just hold things. So they are pulled by the papillary muscle, and that's just to prevent the atrioventricular valves from prolapsing and letting the blood back into the atrium during ventricular contraction. So they're quite important, but I don't know why med faculty have asked so many questions about them. I thought I'd prepare you. So now the significance of the apex beat and displacement, or displacement of the apex beat and sternal heave. Both of those are signs of some sort of hypertrophy of the heart. The apex beat, as I mentioned earlier, is the left ventricle. So if the apex peak is displaced, you've probably got left ventricular hypertrophy. If your sternum is heaving, that will happen because the most anterior part of the heart is pushing on it, and that's right ventricular hypertrophy. They may ask you questions. They might ask you questions about them. And these can be caused by hypertension, or valve disease is a common one for both. And then lung disease or pulmonary hypertension can cause right-sided hypertrophy. Now, septal defects, embryologically, we're going to skip because we don't really have time. But basically, a septal defect makes sense, right? You've got septa between your atrium, you've got septa between your ventricle. If you have a defect in it, you have a hole in it. You've got one naturally which closes and then should stay closed. Or, well, some people have one naturally. It's fairly common to have a patent foramen ovalis, but that should close and then sometimes can reopen again if it's particularly wide, or if for whatever reason the pressure in the right atrium becomes greater than the pressure in the left atrium, which it shouldn't be. Your left atrium and your left ventricle should always have higher pressure in a developed adult than your right atrium and your right ventricle. So the valves, you've got 4 of them. Your semilunar valves are the valves between your ventricles and the respective arteries, whereas your atrioventricular valves are the valves between your atrium and your ventricles. So the 2 semilunar valves are your aortic and your pulmonary valves. The aortic valve is quite important, as is the pulmonary. In fact, they're all important. I don't even know why I said that. But they act as one-way doors for blood. So they stop blood flowing back into the heart while you're trying to pump it out. So aortic, pulmonary, mitral, and tricuspid. You've got one bicuspid valve. You can have congenitally a bicuspid aortic valve, but it shouldn't be that way. So you really should only have one, which is your mitral. It's sometimes also called the bicuspid valve. The tricuspid valve makes sense because it has 3 cusps, and your aortic and pulmonary makes sense because that's the arteries they lead into. The auscultation sites, I'm going to leave to your clin skills lecture, but basically they give us a rough idea of where the valves sit relative to each other. They're kind of useful. This diagram is nice if you can decode it. If not, don't worry about it. So valve stenosis and regurgitation. Stenosis is the valves not being able to open properly. Regurgitation is the valves not being able to close properly. Now, that can be congenital, like as a result of a congenital bicuspid aortic valve, or that can be the result of some sort of disease progression. So that might be rheumatic fever, or that can just be age-related degeneration of the valves. So as you can see here, this is what a healthy valve looks like. This is what a stenosed valve looks like. It cannot open properly because it's become calcified, and it cannot close properly because it's become calcified. Now, when you get a right-sided one versus a left-sided, right-sided is not ideal, but left-sided is the real one you want to worry about, because aortic valve stenosis means that you can end up having insufficient blood supply to your coronary arteries, and we'll go through that in a second. So this is tetralogy of Fallot. I'll just explain these terms quickly. So overriding aorta, that means the aorta is overriding specifically a interventricular septal defect. So it's sitting directly over a septal defect. Your right ventricular hypertrophy means the right ventricle is hypertrophied. The pulmonary stenosis means the pulmonary artery is stenosed, and your intraventricular septal defect means you've got a hole in the septum there. All of this added together creates this tetralogy of Fallot, where basically the blood wants to do anything but go into your pulmonary circulation, which is not good. And so this will require surgical intervention to fix up the septal defect, and usually to try and replace the valves there. Right, your aortic sinuses. Now, this is what I was mentioning earlier. The cusps of the aortic valve are named based on embryology. The only thing you really need to know about them is that it's just the left and right that should have aortic sinuses there. The aortic sinuses are the bits that take blood from your aorta during diastole, where the ventricles pumped it all out, the valve slams shut to stop backflow, and basically the blood just pulls back through those coronary sinus, not coronary, aortic sinuses into the vasculature of the heart. So this is the way your blood goes to your heart. These are technically the first branch of your aorta, although I think they'd prefer it if you said subclavian. Now, coronary arteries and cardiac veins, we can go through all these. I've listed them here, and I've got pictures for you. Have a look. These ones are pretty important. The main ones to worry about are your anterior interventricular, which is a left coronary artery, and that is also called the widowmaker, you might have heard it called as. It's very important. It's this one here, I want to say. Yep, that's it. And the reason that's so important is that that supplies 2/3 of your interventricular septum. And so if that one goes, you're losing a lot of cardiac tissue there, and so that one's got a high rate of death. Then the other important one is probably your posterior interventricular. The most important thing about the posterior interventricular is that it can come from either your right coronary or your left coronary. If it comes from the right coronary, you're right heart dominant. If it comes from the left coronary, you're left heart dominant. What that means is that your blood supply will be more damaged in people who are generally left heart dominant, because if you get a left-sided occlusion, you're losing pretty much the supply to your entire interventricular septum. Now, anastomosis of the coronary arteries. In terms of myocardial infarctions versus progressive occlusion, if you have myocardial infarction, that's a very rapid occlusion of the arteries. Whereas if you have a slower occlusion, then it happens over time, and your collateral circulation, your anastomoses, can compensate for that. So if it occludes very quickly, you will usually have some sort of ischemic heart event, and your heart tissue will die. If it happens very slowly, so like you get an atherosclerosis or sclerosis, and then over time, your heart will basically accommodate for that and anastomose, and you won't necessarily get a ischemic event, although you may have an entirely blocked artery. So these are just some common places that stuff gets blocked. That's the main thing for that. Innervation of the heart, your sympathetics are from your sympathetic trunk and your sympathetic ganglion, and your parasympathetics come from the vagus nerve, which is cranial nerve 10. This is mostly physiology, so they can go through that with you. Pericardial pain versus cardiac pain. Pericardial pain is a pleuritic kind of pain. It's very sharp, it's very precise because it's carried by somatic fibers. So they will know where it is. They'll know, it's usually in the midline, they'll know where it is, it'll be sharp or stabbing, and it will be worse when they breathe. Whereas cardiac pain is transmitted by autonomic fibers, which means it's dull. We don't really know where it's going. So it can radiate to the jaw, the left shoulder, left arm. And it's usually described as a crushing or a heavy pain rather than a sharp and stabbing one. Here are your great vessels. You've got the left great vessels, which are your aorta and your pulmonary veins. So the pulmonary veins come into the left, and your aorta goes out of the left. Aorta then becomes brachiocephalic trunk here, then becomes subclavian, and then your common carotid on the left there, on the right there, I should say. Then your next one is your left common carotid, and then the next branch of it is your left. Your pulmonary veins, all, they're not in this picture, but they just come from the lungs into the heart, into the left atrium. Pulmonary arteries are blood into the pulmonary circulation, and they just sort of go out through the trunk there and go straight out to the lungs. Then your vena cava, you've got your superior and inferior vena cava. Inferior vena cava drains blood from the lower limbs and from the abdomen and all that, whereas your superior vena cava receives more blood from your up limbs and your head and all that. So these ones, have a look at this diagram. I mean, you only really need to know a general gist of it. We won't go through this. This is a coarct aorta and also a patent ductus arteriosus. The ductus arteriosus should become the ligamentum arteriosus that you see, ligamentum arteriosum you see there. If it doesn't, that's a problem. and you just get backwash, and that can overload the right heart. Then the coarcted aorta basically increases the tension here, and you can get the pressure here, and you can get aneurysms, and that's not good either. Then your transposition of the great vessels is a medical emergency. If you have transposed great vessels, you need surgical intervention right away, or you're not going to pump blood in the right direction, and you'll die. And I guess my final piece of advice is just like, chill out. You guys got this. You're all smart enough to do it. And yeah, if you've got any questions, feel free to send me a message, and I'll let you enjoy your next lecture.